Awesome, thank you. So, thank you to all these wonderful folks who are here. It's so great to see you all. It's kind of hard shoes to fill with these wonderful women giving us some wonderful tips. One thing I wanted to say when I started out with is mindfulness meditation in dermatology is an amazing thing. It actually improves psoriasis, eczema, so many stress-related disorders. And so as a dermatologist, we oftentimes recommend that. Something I learned very early on in medical school and I'm a really big force of. And a lot of the things that we'll talk about today will have some overlap into the wonderful lectures that my colleagues also did. So let's get going. And let me just see now. Look at, you didn't hate to get older. I have to look at,
I know. I know.
and then at dinner, we're all turning on the lights on the phone, and my son's going, "Oh my God, really, Mom?" So anyway, I'm actually going to probably use this because it's a little bit easier.
That's what I did.
So this is me on a daily basis. I deal with skin all day. I've loved it. I'm 20 years out, sometimes incredibly amazed how quickly time has passed. And being a dermatologist, it's been a wonderful experience. And really, when people come to see me, I'm obviously, at the first thought, making sure that they're nice and healthy, their skin is doing well, but also to really understanding who they are as people. Each of these people have experienced different lives. They've had different exposures. They have a different genetic background. And one of the things that's so important when I think about evaluating folks and talking and discussing their skin is really who they are and what they have been exposed to. We age in response to a number of things. Chronic ultraviolet light is always the first thing that we think about, we hear about as far as protecting our skin, but there are a number of things that really have us age, and that's gravitational changes. We age, we lose bone, we lose muscle, we lose teeth, subcutaneous fat, and there's a lot of remodeling that goes on as we age. The other is, I'm only laughing because every time I put on some clothes, it's like, wow, 10 years older. So it's always a good thing. But the main thing that we think about when we think about aging is sun damage. And I just want to explain a little bit about sun damage. A lot of us have some misconceptions about it. We get ultraviolet B and ultraviolet A exposure when we go out into the sun. The most damage that we get for our skin is ultraviolet B. It's the main cause of sunburn, tan, and sun damage. Chronic sun exposure and exposure to UVB actually causes mutations in our DNA that result in increased risk of skin cancers over time. And excessive acute sun exposures lead not only to the classic sunburn, but to increases in risks of, or increased hits in the development of skin cancers. In particular, non-melanoma skin cancers. Those include basal cell carcinoma, squamous cell carcinomas, and melanoma. So really important to understand that this is the main form that causes us to have some damage. This is a patient who, this is actually just from off of a set, but a patient who comes to see me in the summertime oftentimes is actually fearful of seeing me if they have this sunburn and they're going, I'm going to get in trouble, and they absolutely do. Perfect classic sunburn. So really something to think about when they come in. This is what we really want to try to avoid. Ultraviolet A is the other type of ultraviolet exposure that we get, and this is actually what causes us the most photo damage, changes like wrinkles, dark spots, pigmentary changes. It's what actually comes through our window in the car most commonly when we're getting exposed. So I can almost inevitably pick and determine if you're the passenger or driver in the car by looking at your skin, just by some aging changes in the skin. These wavelengths penetrate deeper into the skin. They cause more collagen damage. They actually result in some immunosuppression of our skin. So skin cancers that we think about with this are more indirectly related to DNA changes and ultimately the development of non-melanoma skin cancers. So this is what we think of as the bronzing or the tan afterward when we see. So not so much the sunburn, but the tan. This is also causes a dermatologist nightmare when we see this because clearly they had some protection but not enough on their skin. Where do we get our exposure? So we all think about sun exposure as being on a beautiful beach right now in Boston in April would be a wonderful thought and dream of mine. However, we actually get exposure, the most intense sun exposure from tanning beds. One of the most amazing thing to me is when the CDC came out with a recommendation label that was required in all tanning bed salons, which is a very strong organization encouraging people to get tans, that there was a causal direct direct link of use of tanning beds with the development of melanoma skin cancer. So that was such a boon for dermatologists because it is an education that we all need to be aware of. It is such a high intense dose of ultraviolet light, and it really pains me when I'm picking up my Chinese food after work and seeing that there's a group of girls, high school girls, being walked in to get their tan for prom. I mean, it's really our onus to use artificial tanners or other forms of education to say it's not so healthy to get that. But tanning beds in particular, we really should avoid. But this is us every day. We're not on the beach every day walking around. We're actually walking to work, walking to take our kids to running errands, or kids are playing in the playground outside being healthy children. So we really need to make changes and modifications to our lifestyle on a daily basis, not so much when we're out on the beach, in order to prevent a lot of the changes that we have. Another thing that we have to be aware of when we think about the process of photoaging or aging or skin cancer risk is what makes us more prone to getting that. So there are definitely medications that can make you burn a lot easier. This is a very short list. It seems like a lot, but it's very important when you start a new medication. Is one of the things to ask your doctors is there increased risk of me developing a sunburn when I take this medication? And in particular for the dermatologist, it's doxycycline, it is benzoyl peroxides, retin A, things of those natures that make us a little bit more effective. We're all talking about smoking and the significance of it. One of the interesting things about smoking is when you stop, the damage is not reversed. And I think that's really critical. So stopping as early as possible is very important for the skin. You probably recognize someone who smokes a lot. Their skin looks more leathered. It looks a little bit more rough. It's more wrinkled. And those changes, unfortunately, are not reversible. And the other is that as we decrease our estrogen as we get older, our skin loses a lot of the suppleness, the lipid protection that we had in our skin. And so it's very important to have a large contingency of women in their 40s and beyond who are like, Dr. Tsao, my wrinkles are really showing, my skin is very dry. And this is one of the reasons, and it's a necessary change in our lifetime, but really something we have to adjust to. So this is the person who commonly sees me, comes on in and asks for some help. And one of the things I like to point out, and I'm just trying to see if I can see the pointer here. Is this, nope, that's not it. I just turned this off. So one of the things that we think about when we look at our skin is, here we are, is she's had a skin cancer already. There's a little divot in her nose. She has extensive sun exposure, brown spots we call lentigines. People commonly refer to as liver spots, lots of wrinkles. Her skin is a little sallow or yellow in color. And so this is an individual who's suffered a lot of sun damage. So one of the things when I look for first and foremost is really trying to make sure that the patient is nice and healthy. You folks are nice and healthy. So I look for precancerous, cancerous changes of the skin. This is a woman who came in and she said, Dr. Tsao, I have this area that kind of peels every day. It can come and go. It can be a little bit itchy. This is actually one of the precancerous changes to the skin called actinic keratoses, and are very, very well managed by either liquid nitrogen, what's called cryosurgery, or with topical medications that can minimize the potential precancerous changes in the skin by treating this area. And the reason I like to show this slide is when I saw her, not only did she have one patch, but she had multiple little red spots. And so I treated her with a topical anti-chemotherapeutic agent called Effudex and to this area. And lo and behold, there wasn't just one spot, there were multiple spots. And so this whole area represents the potential for precancerous to cancerous changes. And by treating that, you can see how easily we can clear up that area and make it look nice and healthy. So recognizing subtle changes in the skin, these are something for you. If you feel it, it's a little gritty patch or it keeps coming and going, something certainly to let your doctor know about so that it can be looked at. When things are advancing, and these are my gruesome pictures at 5 p.m. Sorry very much. I don't have too many of them, but really important to show. A single patch that's red and scaly on your skin, not healing, getting bigger or changing, certainly could represent a skin cancer like basal cell carcinoma. These are all images of basal cell carcinomas. There are multiple types of them, so there's just not one texture or appearance to them. This is the most common one, which is a slightly raised. It usually has a little dull in the center, may have a little superficial ulceration. This I would worry more about melanoma skin cancer, but is a pigmented variation of basal cell carcinoma, and a very otherwise rare cancer cancer. Basal cell carcinoma is called, it is a basal cell that someone says, Dr. Tsao, I swear my scar is changing. I am not losing my mind. It is growing bigger. And that's a very rare type of basal cell carcinoma. So these are the most common types of skin cancer that we have, and thankfully the most curative and very easy to detect early and get a 98 to 99% cure if we actually manage them. Again, isolated scaly patch on the skin could be a basal cell carcinoma, but this is actually an example of a squamous cell carcinoma. This is the second most common type of skin cancer that we can develop, a little more important to treat because it can metastasize, unlike basal cell carcinomas. And so we certainly like to make sure and do that, just a little close-up vision because dermatologists always like pictures. And the other type that we worry about a lot are melanoma skin cancers. And this is a typical patient for me. They may have these benign growths on their body. They may have 50 of them. And it is my job to really look at each one because out of all these brown spots that this person has, there's one that's atypical. And if I didn't recognize that, it would potentially be a miss for a atypical mole or potentially melanoma skin cancer. Let me just go back one slide. So when we think about melanoma skin cancers or changes in our moles, it's really important to think about the ABCDEs. We want moles to be symmetric in color and shape, have them look as much as they can. If they have asymmetry in either the border, starts to become irregularly bordered, color goes from a brown to a black red, or diameter keeps getting bigger, it's something to let us know about, okay? So let's get into the more fun part about all of this because, you know, it's very important for us to take care of our skin, but most people who come to see me, because I am a laser cosmetic dermatologist, dermatologic surgeon, are really trying to get some healthy habits and erase some of the vices that we may have actually occurred and incurred throughout our lives. And there's 4 essential components that I could recommend for you all to think about for daily care. Strict photoprotection is absolutely key. Applying a moisturizer, exfoliating daily, and potentially applying a over-the-counter or topical retinoic acid. So biggest question that I get every day is, Dr. Tsao, do I need to put on sunscreen? Well, yes. You need to put it on every day, and you need to put on more when you're out more deliberately into the sun. The biggest question I ask is, Dr. Tsao, does it really matter if I use an SPF 15 to 30? And it really does, because if you apply an SPF 15, it filters out about 93% of those worrisome UVB rays. If you increase to an SPF of 30, it filters out about 97% of the UVB rays. This is what the American Academy of Dermatology recommends, at least an SPF 30 sunscreen. They're not twice as effective, but they're certainly more effective when you think about percentages. Broad spectrum sunscreens in the form of titanium dioxide and zinc oxide are at least 90% effective as well. Now, a lot of people are worrying about chemicals in sunscreens. That's in the literature a lot. If you're very worried about them, all you need to do is stick to the physical blocks. Those are your titanium dioxide, zinc oxide products. And those products can be obtained in many sunscreens, but Neutrogena Ultra Sheer, Elta MD, or Vanicream, if you have sensitive skin, are 3 really commonly available sunscreens, and I think they work beautifully. Again, I put on an SPF 85. I walk outside and I tan, but I certainly put it on every day. So use as high a number as you can. There is some validity in increasing the percentage if you can. And again, these are some of the AAD recommendations. I think the biggest thing that people are most shocked about is this is how much it takes to actually put on enough sunscreen on your body. 1 shot glass full of sunscreen. That's actually how much you should use. In your container of sunscreen, that should only last you a handful of applications before that bottle is gone. And the other really important thing about sunscreen is that don't leave it in your car because it actually overheats and it denatures itself. And change your bottle every year. Jen and I talk about this every year. The expiration date is the finest little print on that sunscreen because they don't want you to necessarily buy a new bottle of it, but it'll list right very clearly that it does have an expiration date. That is a valid thing. Change it every season. Just throw it out at the end of the year and get a new fresh bottle at the beginning of every season just to make sure that it's working effectively for you. So 1 bottle should last about 6 applications. All right. The other thing that I recommend folks doing is using some protective clothing. I think the REI, Lands' End, LL Bean all have these UPF protective clothing. I love them. They're wonderful. Coolabar, Solumbra, or another couple of companies designed by patients with skin cancer who really have very attractive sports clothes and everyday clothing line. I was just locally in the Newton store and they had them in there. So definitely think about it. Don't forget your eyes. You should have UPF protective sunglasses because you can develop retinal melanoma, skin cancers in the eye. Very important to protect your vision as well. Artificial tanners are fine. It's like a varnish on the skin, okay? They aren't protective. They don't have sunscreen, so you still need to put on the sunscreen, but you can put these on. They do look very natural, though I usually, as a dermatologist, can tell you to have them on. They actually look very nice. Very good brand is Jergens. You put it on as a lotion every day, and it's a very nice daily slow increase in color of the skin. The spray tans only last about a week to 10 days, but those are very nice for a very quick fix. Again, don't think that they are protective in nature, but they certainly are safe to use. So this is a picture of a patient who I actually saw probably a good 10 to 15 years ago, and with one subtle change, the use of a topical retinoic acid had a significant softening of her crow's feet after 3 to 4 months use. So a very simple application of an over-the-counter retinol, which is a form of vitamin A product to the skin, can really result in some nice improvement of the eyes. Topical retinol or prescription tretinoin actually work in many ways. They inhibit the breakdown of collagen. They're a collagenase inhibitor. They actually increase the thickness of your skin, the epidermis. They make your blood vessels stronger. They exfoliate, so they remove some of the skin damages that we actually have. So once we've actually done our daily regimen, let's get to looking like these beautiful women, the Presley women. This is mom, daughter, and granddaughter. Incredible. That's not really that possible in the world, clearly, as is this, right? Thank goodness for Joan Rivers. I loved her. This is the lioness. She is out and about in New York City. I've seen her several times when I've lectured at the Park Plaza and such. And this is too much. This is where we've gone too far in our desire to actually improve our skin. So certainly something to think about and do. And then when I approach the patient who is interested in trying to improve some wrinkles or discoloration of the skin, I also have to remember that not only does our face age, but the body's attached, and the neck and chest and hands also age. And so anything that we do to change our face, we need to be very careful about, because it will have a mismatch if we don't consider what we're doing for the remainder of the body. So the most common things that we do in the next 5 to 6 minutes that we have, we're going to do some fun discussions about some cosmetic treatment options that we have. The most common thing that we utilize in our practice are botulinum toxins and neurotoxins, and there are a number available. I think the most relevant thing to take from this slide is that botulinum toxin is used in every single medical field these days. I have a list of 200 indications in almost every field that you can talk about for the use of some sort of muscular dysfunction or disorder that has really improve patient care and lives in so many ways. In dermatology, we use it for excessive sweating, use it for migraine headaches, we use it for relaxation of muscles in certain situations. So really a very safe product to use. That's one of the main questions that people ask me all the time. There are some always new neurotoxins on board. This is a new one coming out. I'm only showing you because it's exciting, because it used to be a bit of a monopoly on use of it all, but now we have a brand new one in the air. And what can we do with it? Well, we soften lines. The 11s, or our frown lines, are probably the biggest boon that people come in for. Tired of being told that they're angry. I have professionals who are so very tired of people telling them they look worried or angry. One single injection softens this very much. We can treat forehead lines. We can treat, crow's feet and soften them dramatically, gives it a little lift and opening to the eye area. People who have a very prominent dental show, we actually soften nicely to make it a little bit more natural looking. And we can decrease vertical lip lines. We can improve the dimpling of our chin. We can make necklines that I'm starting to notice on myself a lot softer. This is one of my colleagues sharing this slide with me. So we can do a lot of good things with Botox injections. The one thing that we have to think about is needle injections. And so one of the most revolutionary things for us, and I'd like to share with this, is that we're becoming capable of using topical botulinum toxins for the treatment of wrinkles and sweating and such, and it's really exciting area because we may be able to forego needle injections and really manage it with topical applications. So many people also come to me thinking about trying to reduce some of the wrinkles that have formed as a consequence of past sun exposure. One of the most difficult and most commonly approached questions for me is, how do you treat these little vertical wrinkles of our upper lip? And this was a woman who came in, brought in her granddaughter. I love to show this slide because she said she wants to look like this. And I said, me too. Count me in. So I think anytime we think about these cosmetic treatments, we really have to have a very common sense, realistic expectation of what we can do. And one of the things that we can do is soften the lines with some of the lasers. This is a carbon dioxide laser. It's an ablative laser, meaning it really resurfaces the skin through some heat energy delivered to the skin. And these changes are permanent, and it's fantastic. We work in a wonderful place here in Mass General Hospital. We have Wellman Laboratories that have developed most of the laser technologies that the world uses, and one of them is this device. We have another device called fractionated resurfacing laser. I was one of the fortunate first people to ever use it in 2004 for the smoothing of wrinkles and brown spots. And what you can see on this photograph, I always have to show histo slides as a dermatologist as well, is this is an aged skin that's very, very thin. It doesn't have a healthy thickness to it. It has this stain here is collagen. You can see there's a minimal there. You can see with the laser treatment how much healthier you can make your skin and potentially reduce a lot of the precancerous changes to the skin. So at 30 years old or 35 years old, as this woman is, she'd had weathered a lot of beach time, and just with a single treatment, how much her skin has brightened. And this is with about a 3-day downtime of mild redness and swelling. When we get a little bit older, this would be probably a little bit younger than myself, a little bit more weathering, a little bit blurred lines, a little bit more aggressive treatment of 1 week downtime. This is her at the end of 1 week. You can see marked reduction in wrinkles and brown spots. But this is the problem. You have a little downtime. And so you have to always remember and ask your doctor how much downtime you'd have. I showed you the first picture, so 3 days of mild redness. This latter treatment where she had more benefit, 7 days. But at the end of 7 days, you look good. And so having the right perspective, it looks great, right? And this is one of my favorite slides, only because she came in for some textural changes of her skin, but she actually got a mini upper eyelid lift. You can see we treated over her eyelids and well. A lot of the redundant skin is better. Her skin is taut. It's glowing. She has some tightening. There's a little nose lift. There's a reduction of the wrinkles around her mouth. A really very long-lasting benefit. If you're not interested in the laser treatment and you want to get rid of those vertical lines, we definitely can put in injectable fillers. And it's really a wonderful treatment option for patients. I do not recommend the over-the-counter ones. They're usually capsaicin, coffee, caffeine related. They cause an intense amount of Kardashian-like swelling, not necessarily a little bit painful, very unnatural look. But what we're trying to do with these filling agents is really replace collagen. It's a very unique structure. It's very difficult to do so. We're continually working on it, but really something, areas that we can use them in is in trying to improve temple wasting, little tear trough formation, which is a little hollowing around our eyes, for what we kindly call Marionette Lines, or nasolabial folds, or cheek volume loss. And so we can really do with a lot with the fillers, and you can see some photos here, filling in her Marionette Lines, a softening. This is actually a wonderful option for treating patients with lipodystrophies of any type. Patients who have HIV lipoatrophy, patients who have graft versus host disease, who have lost a lot of their subcutaneous fat, a lot of inflammatory disorders where you really lose a lot of cheek volume. We have filling agents that can really recreate this, and it can last really even up to between 12 to 15 months. So really changes the life of these people who are now healthy, but want to also look healthy rather than look labeled as not well. And so our filling agents really do a beautiful job. They're also available for folks who are not surgical candidates. This is a patient who has very, very lax skin, did not want to have a lift, had too many any comorbidities to do so. We did a filling agent, not gone, but better. Right? And so again, these are things that we can do to really make it better. Remember, we age everywhere. If her face looked great, we have to think about the hands, and treated and untreated with the filling agent really can make you have a very nice look. These are with some of our fillers like Radius, Restylane, Lift, other wonderful photos. We're a changing demographic. I'm really a big advocate. I'm actually director of our Ethnic Skin and Color Clinic here at MGH, and I'm really very interested in trying to minimize pigmentary changes that we notice in our skin as a consequence of acne, trauma to the skin, eczema, folliculitis that can really be quite a burden to people in the form of what we call post-inflammatory hyperpigmentation. It's a very, very emotionally stressful change to any of us to have a brown, persistent mark on our skin. And in particular, if it's associated with ongoing underlying illnesses or injury or inflammation. And what I basically do is try to really determine where this pigment is. That helps to guide me as to where I can actually manage this type of pigment. It can be on the top layer of the skin called the epidermis, a little deeper. It can be on the face and not on the face. The most common thing that many of us are afflicted with as we enter our 20s and 30s is melasma. This is a very emotionally distressful pigmentary disorder because it's persistent in nature. It can be limited, it can be full face, it can affect men, it can affect arms, and it can be really debilitating for patients. So some of the research that we do now is in really trying to figure out how we can reduce this melasma, and a lot of it is due to inflammation. And so I'm actually in the process of doing a study to really see if we can target the vascularity of the melasma and really improve it, and it's really done so. I need to end soon, other than to say with photoagent dyschromia, it affects all of us no matter what ethnic background we have, and there are so many treatment options that we've touched on today that we can do, but one of the things that I can always say is it's most important to use sun protection. There is definitely camouflage makeup available. One of the best camouflage makeups, if you ladies need to know, is available at Macy's. It's called Dermablend, and it is fantastic. It really does cover beautifully, not only brown, but red, and in the form of some rosacea or other conditions, and you just have to type in your zip code on the website, and they'll tell you the closest center to have it, but generally Macy's will have it. Remember to maximize your topical agents with, again, retinoic acid, a sunscreen, moisturizer, and think about some of these procedures that we have. Always happy to see you. I hope that we all age gracefully. It's very important to do so, but otherwise, if you're ready to get a little boost, come and see us over in dermatology. Thank you very much. Appreciate that.